I'm Dr. Jarelys Hernandez, and I'll be talking about coronavirus disease 2019, COVID-19 conjunctivitis. So just to define SARS-CoV-2 and COVID-19, we see that both terms are used interchangeably, right? But SARS-CoV-2 is actually the etiologic agent of COVID-19, and COVID-19 stands for novel coronavirus disease 2019. So in December, the virus, right, SARS-CoV-2 emerged in Wuhan, China, and in January 20th, it was declared as a public emergency of international concern by the World Health Organization. Then eventually in February 11th, the name COVID-19 was given by the World Health Organization. Now, SARS-CoV-2 stands for Severe Acute Respiratory Syndrome 2, and this is the agent, as I mentioned, that caused COVID-19 and is an enveloped beta coronavirus and is made of positive single-stranded RNA. Now, as probably all of us know, symptoms may develop 2 to 14 days following exposure to the virus. And this is more or less how we're doing. This is as of yesterday evening. So worldwide, more than 4 million cases, 323,000 deaths. And in the US alone, more than 1.5 million cases and more than 90,000 deaths. So this was extracted from the World Health Organization dashboard. And you can see the link at the extreme left where I got the data from. So typical manifestations, this is a list of the most common symptoms that when patients present with COVID. With a quick search in PubMed, you can come up with different kinds of papers, explaining the presentation of patients with COVID-19, and the same if you go to the CDC website. Classically, fevers and chills, specifically fevers and respiratory symptoms, some cough and respiratory distress, but we do see pretty commonly diarrhea, sore throat, on myalgias as well. Now, COVID-19 can be pretty benign for the most part, but we see atypical manifestations and complications, particularly after the first week, and mostly related to CRS or cytokine release syndrome, which is accompanied by multi-organ failure. Now, we do see acute conjunctivitis as well here as part of other manifestations or complications of COVID. We see ARDS or myocardial injury by direct cause, probably by direct viral damage, or because of CRS. We see acute hepatitis, encephalitis, AKI. Kawasaki-like disease was in the news the other day. Lots of thrombosis, stroke, skin manifestations as well, and so on. Now, I'm going to focus on COVID-19 conjunctivitis because last month when I was working in the COVID unit in Tampa General Hospital, we had 2 cases and that caught my attention. So I wanted to investigate more on the topic. And to be completely honest, there's not a lot out there in the scientific and medical literature. But I tried to gather what we have to present to you guys. So COVID-19 in the eyes. So we know that coronavirus has been previously reported to be associated with conjunctivitis in animals and humans, but in humans has seemed to be mild and rare. And we do know that, we have ACE receptors in lungs, kidneys, gut, but we do have ACE2 receptors as well in our retina and vascular retinal pigment, epithelium choroid, conjunctival epithelia as well. And we also know that the S protein attaches to the ACE2 receptor, allowing endocytosis of the virus, and that's how cells get infected. So more or less, we think, that because we have ACE2 receptors in our eyes, probably that's one of the mechanisms of infection, but it's not clear yet. If that happens by direct contact, probably, or somehow in the tears, the virus will get accumulated over time somehow. So how does it look like? Patients can present with conjunctival hyperemia, foreign body sensation, epiphora, which is all this tearing, chemosis, mild eyelid erythema or periorbital edema, pruritus, burden sensation, some present with mild pain. And it's we also know that symptoms they progress and they get more and more severe, and then eventually they get better. But patients definitely report that some worsening before it actually gets better. And it has been reported that clinical exam findings are most consistent with follicular conjunctivitis. Now, in the palpebral conjunctiva, we have different follicles that get inflamed, and it looks kind of bumpy, and that's what we see here in the pictures at the right. It's like a demonstration of how follicular conjunctivitis looks like, and we see the injection in the conjunctiva. We see the swelling and some chemosis. Conjunctivitis due to COVID-19 can rarely present as an initial manifestation of the disease, right? But there are some case reports where patients actually come in on day 1, 2, 3 of illness, complain of ocular symptoms. But for the most part, we see those symptoms develop afterwards, more or less approaching the second week or during the second week. And they also have systemic symptoms. Now, Lafredo and colleagues, they did a meta-analysis. They did 3 studies with more than 1,000 patients. That's the data that they used in their meta-analysis. And they reported that the incidence of conjunctivitis in the inpatient setting was 1.1. And this was a study that they did in Italy. Now, 3% of these cases were due to severe COVID-19, and 0.7 due to non-severe COVID-19. So ocular presentation in the context of severe COVID was more common. Because patients with ocular complaints are sicker or have systemic symptoms, we do see an elevated white blood cell count, neutrophilia, and high markers of inflammation like procalcitonin, CRP, and LDH when compared to patients without ocular symptoms. One colleague, they published a case series including 38 patients with COVID in China, and they found that 12 of the 30 patients, meaning 31%, presented with conjunctivitis. So based on this study alone, conjunctivitis perhaps seems to be prevalent in the COVID-19, we take all the COVID-19 patients. So let's talk about conjunctival swabs. I think we're more familiar with nasopharyngeal swabs. We order them all the time, and that's the one that we know best, I guess. But one colleague also reported that we're talking about still about the same study, that 2 of the 12 patients that presented with ocular abnormalities, 17.7% of them had positive results for SARS-CoV-2 on conjunctiva and nasopharyngeal swab. But mostly it was like 90 of the 30 patients, like 90-something% had positive nasopharyngeal swabs. But then we see that only 2 of the 12, that's a group with ocular symptoms, only 16.7% had positive conjunctival swabs. And this raises the question that potentially not all COVID-19 related conjunctivitis will yield positive SARS-CoV-2 PCR upon testing of conjunctival swabs. And it seems that just like SARS-CoV-1, there's a low prevalence of SARS-CoV-2 nucleotides in the tears. Shen and colleagues, they reported a case of a 30-year-old man that presented to the hospital in Shenzhen, China, with confirmed COVID-19, and he had bilateral acute follicular conjunctivitis, and he presented on illness day 13. They were able to get conjunctival swabs on day 14, and they turned to be positive. He recovered, or his illness resolved on day 19, and that's the day his conjunctival specimens became negative. So he was not sick, or his eye complaints resolved relatively quickly in this young guy. But this information or this data suggests that viral load in conjunctival specimens perhaps will decrease gradually over time, with probably less potential of transmissibility and accompanied by improvement of ocular symptoms. Now this is our guy here. They were able to do slit lamp exam. Panel A and D, that's the exam for on illness day 13 when he presented. B and E show an exam on day 17, and then the panels C and F, that's examination on illness day 19 when he actually reported improvement, and clinically you can see that his clinical exam findings look much improved. Now, this patient in particular, he received lopinavir and ritonavir, and he received ribavirin eye drops. Now, are tears infectious? It remains unclear how SARS-CoV-2 accumulates in ocular secretions. I'm sorry, I mentioned that previously. Colavita and colleagues, they presented the first confirmed case of COVID-19 in Italy, and it was a 65-year-old Italian female that had traveled from Wuhan to Italy. And she presented on illness day 2, complaining of upper respiratory infection symptoms and bilateral conjunctivitis. Now, they did ocular swabs on her that turned to be positive, and they did serial swabs on her, and they were positive from day 3, from hospital day 3 through the 21st. And interestingly, Colavita and colleagues, they were able to inoculate Vero E6 cells with the first RNA positive ocular sample from this lady. Vero E6 cells are epithelial cells from the kidney, from this primate that I'm showing here. So they were able to see cytopathic effect 5 days post-inoculum, which means that, or supports the idea that yes, these tears are infectious indeed. We do need more research to evaluate the transmission through ocular secretions though, but based on this study alone, it seems like yes, they are infectious. Treatment. Now, COVID-19 treatment is essentially supportive, and patients definitely complain that it kind of gets worse before it gets better. We do treat COVID-19, or in an attempt to treat it, we use different agents, convalescent plasma, interleukin-6 inhibitors, and so on. But specifically for eye complaints is supportive care. What we are doing now until we have more evidence if something else is needed. So artificial tears, antihistamine eye drops like olopatadine are used, cold compresses. Sometimes the artificial tears can be cooled a little bit for more symptomatic relief, and topical antibiotics can sometimes be used to prevent bacterial spore infection. As far as outcomes in general, the symptoms may last from 14 to 30 days. Probably by the 2nd to 3rd week they may resolve, but it depends. It varies depending on the underlying risk factors and characteristics of the patient. But so far, no reports of COVID-19 patients experiencing blurred visions, of conjunctival hemorrhage, eyelid ecchymosis, conjunctival scarring, or pseudomembrane formation, though there was one case reported by Shima et al. Of keratoconjunctivitis, and in the right you can see a picture of that patient with keratoconjunctivitis presumed to be due to COVID-19, and that's actually a picture that the patient himself took. And here's the reference for that. Now, ocular manifestations of COVID are thought to be self-limited, and there are no reports of sight-threatening manifestations, thankfully, at least so far. But we do need larger studies, as I keep mentioning, and long-term follow-up to better understand this process. So I'm going to move ahead and present those 2 cases that I had while I was working in the COVID unit in TGH. So case A, it's a 60 Yale male, and his past medical history was remarkable for CAD, hypertension, and hyperlipidemia. He presented on illness day 8 with complaints of cough, dyspnea, and exertion fevers. Because of his presentation, he was deemed to have moderate to severe COVID, deemed to be cytokine release syndrome grade 2, and hydroxychloroquine was started. And he also was started on antibiotics for possible superimposed bacterial pneumonia. So he was started on ceftriaxone and doxycycline. On day 2, his respiratory status declined. So since admission, the first 24 hours were crucial. He deteriorated pretty fast, and he required mechanical ventilation. So he progressed from CRS grade 2 to CRS grade 4. And he also required vasopressors. Norepinephrine infusion was started in hospital day 2. The next day, steroids were given. For the most part, steroids were given to patients with severe ARDS or for symptomatic relief in the context of COPD exacerbation and so on. At least that was the management in the COVID unit for steroid use. But he received methylprednisolone once, and he was given tocilizumab, which is an interleukin-6 inhibitor on hospital day 3. We continue to see multi-organ failure in this patient. He requires CRRT because of his AKI. His renal function was completely normal before. And then on day 6, because initially we saw an improvement in his inflammatory markers. However, they started to creep up again, and a second dose of tocilizumab was given. For the most part, we don't see that. Typically, it's only one time. On day 7, he was able to come off pressors, and then in day 9, he was extubated and he was able to remain on room air. Now, on day 11, we noted that the patient had worsening bilateral eye erythema and pain, and his eye exam showed conjunctival injection and inferior chemosis. So these findings are consistent with acute viral conjunctivitis, essentially. So ophthalmology helped us with the case, and they concurred that it was due to COVID-19, and artificial tears were provided. We tried to get conjunctival swabs, but when we called the lab, we had some difficulties because the equipment was not validated to run this type of samples. So for this case, we were not able to see that. Now, on hospital day 19, he was able to be discharged home. By that point in time, his ocular symptoms were nearly resolved, and that was his illness day 26 for him. And his SARS-CoV-2 PCR from nasopharyngeal specimen remained positive at the time of discharge. And unfortunately, he required patient dialysis because of his severe AKI. Now, moving to the next patient, also a gentleman in his 60s. He was 69, and he had chronic illnesses as well. Stage 3 squamous cell lung carcinoma, and he was on weekly chemo. He was on docetaxel. This gentleman was diabetic and he had CAD as well and PAD. He presented on illness day 14, a little later than our previous case, and he was complaining of progressive dyspnea, cough, dry cough, and eye pain that was bilateral but worse on the left eye. He had conjunctival erythema, pruritus, and foreign body sensation when he presented. Also deemed to be COVID-19, moderate disease. He was diagnosed with a nasopharyngeal swab as well. And because he had moderate disease, hydroxychloroquine was started for 5 days. Now, on hospital day 2, he was enrolled. He agreed to be enrolled in a double-blinded randomized control trial with sarilumab, which is a interleukin-6 inhibitor as well. For this study in particular, there is a 20% chance of getting placebo. Eventually that day, he was noted to have worsening left eye swelling and pain specifically. And there was a small surge of lesion that probably was there before, but it was not, I guess, reported. And that small lesion was anterior to left lower eyelid, as we can see in the picture. So, excuse me 1 second. Okay, so his left eye swelling was significant enough, and toward a CT imaging of facial bones to see what was going on, and findings were consistent with left-sided perceptal and facial cellulitis, as the arrows are showing here. And he had a subdermal fluid collection measuring 1.5 centimeters max diameter, and he was started on vancomycin and ceftriaxone for his perceptal/facial cellulitis. Oops, sorry guys. Now, going to hospital day 7, conjunctival swabs and a swab of the left lower eyelid ulcer were collected. So this time we were able to run SARS-CoV-2 PCR on those specimens. However, he turned to be positive for herpes simplex virus 1 PCR, both eyes and the left lower eyelid ulcer. He was negative for SARS-CoV-2, he was negative for adenovirus, varicella zoster virus as well. All that was negative. So for his confirmed HSV1 conjunctivitis, and given the complexity of his case, the decision was made for him to start oral antiviral, so he was started on famciclovir for 7 days. And supportive care was provided as well, with artificial tears, cold compresses, antihistamine drops, and erythromycin ointment to the herpes lesion that he had in his left lower eyelid. So respiratory-wise, even though his eye symptoms were more complex, I guess, than our previous patient, his respiratory symptoms were not as severe, and his oxygen requirements never exceeded 4 liters. He was able to be discharged in hospital day 10. That was illness day 23 for him, and he has conjunctivitis almost completely resolved by the time of discharge. But he had to be discharged on 2 liters of supplemental oxygen for exceptional dyspnea. His antibiotics, his IV antibiotics for the perceptal and facial cellulitis were transitioned to oral cephalexin and doxy, and he was instructed to complete 14 days of antibiotics. Now, for this guy, he was never told that he had herpes before. He never had any eye issues before, no oral ulcers in his mouth or genital area or anything like that. So he was pretty surprised, when the diagnosis of herpes conjunctivitis was given. Now, learning points regarding COVID-19 conjunctivitis. Ocular complications have not been widely reported, as I mentioned, and ocular symptoms affect more commonly patients with severe disease. And potentially not all COVID-19 related conjunctivitis will yield positive SARS-CoV-2 PCR when we test the conjunctival swabs. We don't know how SARS-CoV-2 accumulates in ocular secretions, so that has yet to be elucidated. And further research is needed to evaluate transmission through ocular secretions, though we do think it's possible, and we have some evidence to support that. Supportive care is the mainstay of treatment of COVID conjunctivitis. Now we know that for the systemic symptoms and complaints, we're still trying to figure out what's the best, but we have all these things that we use, like convalescent plasma and so on. In COVID-19 conjunctivitis is thought to be self-limited, and there are currently no reports of sight-threatening manifestations locally. And that's it. That's all. Any questions?